A baby is growing and going to the school, and the teacher says to the parents, I feel like you need to talk with doctor because your baby is not making any group, not playing with the group, not making peer, and not paying concentration to the study, not attentive to the lesson, and it's really isolated, and I see your baby is too much drowsy and sleepy. Why is this? It is one of the cause is hypothyroidism. And sometimes parents will talk to, or just opposite for another baby. What is the complaint they will tell? Your baby is very unattentive, moves every corner of the school or in the classroom, and don't pay concentration on the task not more than 1 minute. He loves to do, or she loves to disturb the other students. All the time is restless. Just opposite. And this baby is very hungry. They are very hungry all the time. Hyperdynamic, you can say. Just opposite, because hyperfunction of the thyroid gland. See, this is very important. That's why during pregnancy, if mom has thyroid problem, hyperfunction or low function, hypofunctions, both of them must be treated by the doctor. Otherwise, the baby may have problem in the thyroid gland. So, baby's growth may be interrupted. That's why it is very, very important. Okay, so embryogenesis we understood. Now we will go over the anatomy. Now I like to tell one thing with that diagram. You notice that thyroid gland is descending from the base of the tongue. But my question, if thyroid gland does not descend anymore after this, if thyroid gland does not descend after this, then where the thyroid gland would be? Close to the base of the tongue. You're not going to get the thyroid gland here. Thyroid gland can be here, before coming to the final destination. Okay, so thyroid gland can have some ectopic location. Even the thyroid gland can come into the thoracic cavity too. There is an ectopic location. There is some accessory thyroid tissue in the neck. What is accessory? Not only ectopic, accessory. Extra piece. So then what going to happen? Thyroxine level will go up or down? Up. So how we gonna understand that this is extra or accessory lobe of the thyroid gland? We have to scan nicely. We have to understand how does it look like the thyroid gland. Thyroid gland is a homogeneous, medium level hypoechoic. And thyroid gland is coarse in texture. The same kind of tissue if you see in the neck, then you're going to click the color, then you will see that extra tissue, that is the thyroid gland, has a hypervascular, or the vascularity is there, and it looks same as the other thyroid gland. And do the blood test, you will see the thyroid hormone is high. So in that way, accessory. But you have to have that knowledge that thyroid gland development or embryogenesis is very important because of certain issue. That knowledge you have to have. And now anatomy. The anatomy, the size, the length, size of the lobes, Usually the left lobe is little smaller than the right lobe. Left lobe is little smaller than the right lobe. So lobes are usually has length, height and width. The length is 5 to 6 centimeter. In height, you will see 2 centimeter. Okay, 2 to 3 centimeter. And the width, height, and width. Okay, height would be little less. Let me. Some 2 centimeter is the most of the time, 2 to 2.5 centimeter. The width would be 2 to 3 centimeters. Okay, so now this size is very important because when the thyroid gland is enlarged, then you will see the length is more than 6 centimeters. Very few cases I found that it is 6 centimeter, but mostly it is 4 to 5 centimeter, 4.5 centimeter. Okay, so that's the way we do. So if I give you this figure, say 4 to 6 centimeter, it fits better. Okay, it fits better. But there is a lot of variations of this size. So size doesn't matter if there is no complaint. But if there is a complaint, the size is very important because some pathology in the thyroid gland affects the size of the gland. Okay, so now you get the size, then isthmus. Size of the isthmus. What is isthmus? Isthmus is the connection between the two lobes. And this is the thyroid tissue. Same thyroid tissue. The isthmus, we measure the AP. AP means height. And keep that in mind. It is 2 to 6 millimeter. You don't need to know the length and the transverse. Okay, usually we measure the AP, that is height, it is 2 to 6 centimeter. But if you want to know the length, I can give you length usually so 2 centimeter. In transverse there is a width, it is also 2 centimeter. We found, but okay. But this is the priority, height. Because we, in the protocol, we measure the height of the isthmus. And the right lobe may be somewhat larger than the left lobe. Okay, so now right lobe is little bigger than the left lobe. Okay, so now shape and contour. Lobes are oval in shape, have a boat-like appearance. So in sagittal view, you will see the thyroid lobe is just like a oval shaped or boat shape. Okay. Boat shape. It is encapsulated by the fibrous capsule, which gives the thyroid a smooth contour. So it has a smooth contour. A smooth contour means in sonography you will see the thyroid gland. Okay, see the capsule, it gives the smooth contour. Okay, it gives the smooth contour. Now we're going to discuss about the vasculature. Keep that in mind, all endocrine glands having more than one arterial supply, it needs to be hypervascular. Why? Because they are ductless gland. They produce hormone, and the hormones must go into the blood by diffusion. That's why it has to be highly vascular. So now we're going to discuss about the vasculature. So arterial supply. There are 3 arterial supply. Okay, let me draw that diagram, then you will figure it out that who is what. Okay, if this is the thyroid gland in the neck, the common carotid artery is going up, then it is split into 2. This is common carotid artery, this is carotid bulb, this is ICA, internal carotid artery, this is ECA, external carotid artery. Okay, the thyroid, okay, and the aortic arch is passing like that. I'm just it has to be. So this is aortic arch. Thyroid gland arterial supply, number 1. You'll see the thyroid artery. Thyroid artery usually it comes from a direct branch of common carotid artery or aortic arch. This is aortic arch. Number 2, superior thyroid artery. Superior thyroid artery, it is a branch of external carotid artery. It's a branch of external carotid artery. They said superior thyroid artery is the first branch of external carotid artery. Number 3, inferior thyroid artery. It is a branch of thyrocervical trunk. Thyrocervical trunk. Thyrocervical trunk is a branch of thyrocervical trunk is a branch of subclavian artery. So inferior thyroid artery is a branch of thyrocervical trunk. Thyrocervical trunk is a branch of subclavian artery. And this inferior thyroid artery goes superiorly upwards and goes in front of the vertebral artery and longus colli muscle. You don't need to know that much, but know who is whose branch. Thyroid artery, it comes from the direct branch of the common carotid artery or aortic arch. That means this is common carotid artery. So this is thyroid artery, and thyroid artery will go to supply the thyroid gland. Okay, it supplied the thyroid gland. Now superior thyroid artery is a branch of external carotid artery. Superior thyroid artery is coming. Superior thyroid artery has 8 branches, but this is superior thyroid artery. Superior thyroid artery. Superior thyroid artery supply blood from the top part of the thyroid gland. It supply blood to the upper pole, and it communicates, it has a collateral circulations, and it communicates or anastomose with the carotid artery. Thyroid artery. So this is thyroid artery. And this is superior thyroid artery. And inferior thyroid artery, okay, when the thyroid artery comes from the aortic arch, so this is Thyroid artery. Thyroid artery when it comes from the aortic arch. And the last one, so this is brachiocephalic trunk, BCT, and this is subclavian artery. So this is subclavian artery. Subclavian artery, first branch is the vertebral artery, and another branch is thyrocervical trunk. So vertebral artery goes up. So this is vertebral artery, VA, vertebral artery. And from the subclavian artery, the thyrocervical trunk arises and it goes the inferior thyroid artery. It supplies the inferior part of the. So now this is thyrocervical trunk. From the thyrocervical trunk, this is the inferior thyroid artery. Inferior thyroid artery. Okay, so thyroid gland is very well perfused with the three artery. One is thyroid artery, second is superior thyroid artery, third is inferior thyroid artery. So thyroid artery comes from either CCA, common carotid artery, or aortic arch. Superior thyroid artery is a branch of external carotid artery, is the first branch. Inferior thyroid artery is a branch of thyrocervical trunk. This is thyrocervical trunk. And the inferior artery is a branch of thyrocervical trunk, and that goes in front of the vertebral artery and the longus colli muscle. Then it goes into the inferior part of the thyroid gland or the lower pole of the thyroid gland. All those three arteries makes a anastomosis, a little branches from each will communicate each other and make a collateral circulations. Then what is the importance of these collateral circulations? The importance of collateral circulations is, if by any chance one artery is obstructed, so the thyroid gland should not die off. So the other artery, they can compensate that blood, and the thyroid gland has no problem. Okay, so this is the story of the thyroid gland, arterial supply, and the venous drainage. The venous drainage will be thyroid vein that drains into the internal jugular vein or brachiocephalic vein, and the superior thyroid vein, middle thyroid vein, and the inferior thyroid vein. Okay, so these thyroid vein are in three positions: superior, middle, and inferior. All of them drains blood into the internal jugular vein. Okay, so now, so this is arterial part. So now I'm writing here the venous part. Venous drainage. Thyroid veins. So that thyroid vein has superior thyroid vein, middle thyroid vein, and inferior thyroid vein, and all of them drains blood into the internal jugular vein. Internal jugular vein. And we know that internal jugular vein and the subclavian vein drains blood into the brachiocephalic vein. And brachiocephalic vein on the right side and on the left side. They joins together, forms the superior vena cava. Superior vena cava drains into the right atrium. Drains into the right atrium. So now I will give the little informations. That internal jugular vein is coming like this, and subclavian vein is coming. Now joins together, forms the brachiocephalic vein. So this is internal jugular vein. This is subclavian vein. They joins together, forms the brachiocephalic vein. And brachiocephalic vein on the right side and brachiocephalic vein on the left side. They joins and forms the superior vena cava. And this superior vena cava drains into the right atrium. So if a patient have the right heart failure, right, that means right atrium cannot take any more blood, and right atrium cannot pump. So then what's going to happen? All those venous drainage will be back up. When the backup will take place into the thyroid vein, so thyroid gland will have backup too. So it will be too much congested. And when too much backup of the vein as blood, so arterial blood, artery will say, oh my God, it is too resistant,